Hello, my name is Kieran O'Dwyer, and today I'll be guiding you through the neuromuscular condition cerebral palsy. Firstly, I'll briefly describe what cerebral palsy is, and I'll also outline the different types and talk about its current prevalence in Australia. I'll then talk about how it's caused, what its physiological processes are, and the typical signs and symptoms involved. Thirdly, I'll go into detail about the types of cerebral palsy and the effects on movement control that they have. Finally, I'll evaluate the existing literature on exercise programming and talk about the current exercise guidelines before concluding the presentation. Cerebral palsy, CP, involves a range of non-progressive syndromes of posture and motor impairment, causing activity limitation. It is often accompanied by other neurodevelopmental disorders such as specific cognitive or visual deficits. Nearly half of these conditions are diagnosed in premature born children, children born before 37 weeks gestational age, and the other half in full-term born children, 38 to 42 weeks of gestational age. Worldwide, there are 17 million people who are diagnosed with this condition. In Australia, there are 34,000. 1 in every 500 babies born in Australia is diagnosed with CP. That is a baby born every 15 hours. This condition is classified according to the type of motor dysfunction and the injury location in the brain. Each type is defined by which part of the brain is impaired. The most common is spastic cerebral palsy, which arises from motor cortex damage and accounts for 70 to 80% of all diagnosed cases. The other main types are dyskinetic, ataxic, mixed, and hypertonic. And I'll go into further detail into these later on in the presentation. Causes of CP. There is no single cause of cerebral palsy. CP is caused by damage to a developing brain, which can involve a wide range of factors. It used to be common thought that CP was developed by complications during birth. However, studies have shown that 80% of CP development occurs from events and factors before birth. Although it is hard to pinpoint a direct cause of it, it is correct to say that a set of predisposing antenatal, perinatal events and postnatal factors act together on a developing brain to cause CP. Predisposing factors include congenital abnormalities such as cleft lip, gut atrocias, and hypospadias. Genetic factors, such as thrombophilias, have been found to increase the risk of CP if accompanied by other factors. Toxic substances, such as alcohol, have been shown to be associated with the rare brain malformation, lisp. Additionally, it has been found that alcohol will aggravate the damage caused by any ischemic or exotoxic event. Exposure to a range of infections and viruses have been shown to be associated with preterm birth and CP. In preterm birth, normal development of the brain could be altered due to separation of the fetus from its natural environment. Additionally, placental involution can happen when babies are born postmaturely, which increases the brain's risk to damage. Other factors, such as thyroid issues, menstrual issues, gestational diabetes, have been associated with neonatal encephalopathy and CP in full-term babies. During the perinatal period, hypoxic ischemia, refusion, and infection inflammation both can play a part in increasing the risk of CP in the developing brain. Additionally, postnatal factors can include socio-economic level, mother-baby separation, nutrition from the placenta, and chronic hypoxia. Signs and symptoms. In babies, signs and symptoms can include low muscle tone, muscle spasms, poor posture, reflexes and muscle control, feelings of stiffness, not being able to sit by 6 months age, difficulties in eating, and one side of the body preference during movement. Symptoms in children can include not being able to say full sentences by 2 years old and not being able to walk by 1.5 years old. Additionally, in full expression, symptoms are represented in different forms in different types. In the spastic type, the motor symptoms are muscle weakness, muscle shortening, and increased resistance to movement. In the dyskinesia type, they include involuntary postures, continuous switch of slow and jerky movements, and the ataxia type, they include muscle incoordination, weakness, and shaking during voluntary movements. In individuals with spastic CP, the effects on movement control can be quite severe, as it is caused by damage to the motor cortex. Spasticity refers to neuromuscular overactivity, resulting in excessive skeletal muscle contraction. This type accounts for the vast majority of CP. Its effects on the arms and hands can include constantly bent elbow, flexion at the wrist, flexion at the fingers, causing the fingers to be fisted, and these can lead to difficulties with getting dressed, washing and toileting oneself, eating and drinking, writing, moving and controlling objects, and it may also affect the person's ability to use their arms for balance, which can lead to difficulties standing and walking. Its effects on your legs can include flexion at the hip, adduction or scissoring of the thighs, flexion at the knees, equinovarus foot posture, which is collapse of the ankles, hyperextension of the big toe, and this can affect an individual's ability to stand upright, sit upright, move from one position to another, and move and reposition in bed, and also can affect walking and running. Common types are hemiplegic, paraplegic, and quadriplegic. Hemiplegic means that one arm and leg on one side is affected, with the other side being completely or almost unaffected. Paraplegic means that both legs are only affected, with the upper body usually showing normal ability or minimal signs of CP. Quadriplegic, all four limbs are severely affected, and this poses the greatest difficulty in walking, and some individuals with this much brain damage are often wheelchair bound. Dyskinesia and ataxia. Dyskinesia is caused by damage to the basal ganglia of the brain. Dyskinesia CP refers to involuntary movements which happen outside of the individual's control. These can include dystonia, twisting and repeating movements, asetosis, slow movements, and chorea, irregular, unpredictable movements. Ataxia is caused by damage to the cerebellum. This particular type of CP involves unsteady, shaky tremor-like movements, difficulties maintaining balance, and trouble in doing many of the day-to-day activities. Interventions. There are many interventions in cerebral palsy, and to assess them correctly, we want to break them up into categories. Interventions for movement control, muscle, bone, and joint issues are of utmost importance and can include procedures such as SDRs that have been shown to be effective on a small percentage of individuals in reducing the symptoms of spasticity. Additionally, in an attempt to help older children reduce pain and improve movement, joint deformity removals and muscle lengthening procedures have been used. As there are many trials in having CP, and many of the day-to-day activities that people without CP find easy, people with find hard, physiotherapists and occupational therapists can be utilized in order to help strengthen muscles and encourage movements such as sitting, standing, walking, and toileting. Furthermore, equipment such as casts, orthotics, wheelchairs, seating, and walking frames are all used to help this movement. Many children with cerebral palsy benefit from botulinum toxin type A injections into muscles affected by spasticity. This intervention is used from about 2 years of age and is most effective when used in conjunction with therapy. Additionally, other medications to help with seizures and pain are frequently used. As CP affects more than just movement, there are other interventions which are needed to help with sleep, behavior, emotion, and communication issues, which are all part of the struggle for a young person. Popular and effective methods include counseling, therapy, speech pathology, and behavioral work, and a variety of many others. It has been stated that there is no cure for cerebral palsy. However, there is speculation that magnesium sulfate can reduce the risk of cerebral palsy. It is given to pregnant mothers who are about to birth very preterm children. I found 2 studies which researched this issue. One created in 1995 by Nelson and Grether, which found that magnesium sulfate could create a protective effect against CP in very preterm children. Comparatively, Rouse et al. In 2008 found that MS did not reduce the risk of CP, but found that CP did occur significantly less frequently in the MS trial group. As we have just discussed, CP has varying degrees of severity and symptoms, and so exercise prescription must be treated with care. That being said, it is outlined by the Australian College of Sports Medicine that the same guidelines for exercise in general population can be used on individuals with cerebral palsy. Of course, modifications will have to be considered and made though, and when coming up with an exercise plan, it must be kept in mind that clients with CP have a lack of motor control and are prone to early fatigue. A review done by Dodd et al. Reviewed 11 studies concluding that overall strength training done 3 times a week could improve strength and help motor activity in individuals with CP. Additionally, in all the studies done, there are no reported side effects as well. An analysis done by Mclean et al. Was conducted, and it assessed the effect of a 3-session-a-week, 6-week strength program intervention on 11 young people with CP between the ages of 8 and 18. The main exercises used were all compound lower limb exercises such as bilateral squats, heel raises, and step-ups between the ranges of 8 and 12 reps per set. Aside from the expected increase in strength, this intervention found that activity participation was increased, as well as reduction in activity limitation and perception of activity limitation. Furthermore, aquatic exercise was also found to be an encouraging form of exercise due to reduced joint loading and helpful properties of the water. This particular form of exercise was encouraged with individuals with more severe movement limitations. Further benefits include increased social bonding, increased social participation in activities, both community and solo, increased self-esteem, reduction in anxiety and depression, reduction of secondary conditions, increased movement coordination, and increased cardiovascular efficiency. Exercise prescription. There are no outlined frequency, intensity, volumes prescribed as conditions and abilities vary. Modifications must be made to the ACSM training principles in order to account for these conditions. Emphasis should be on lower limb strength training and aerobic exercise. Beginners should start with 40 to 50% VO2 peak, and then they can increase to up to 80% once confident for 20-minute bouts. Stretching and relaxation sessions should be included throughout the session to decrease fatigue and help participation. And of course, slow dynamic exercises should be completed to full range of motion, with emphasis on postural alignment and focuses on imbalances. 3 times per week is recommended. And of course, warm up and cool down is essential in developing any program. Cerebral palsy encompasses the group of disorders which affect movement and posture, resulting in limitation in a variety of activities. Just to clarify, this disorder is caused by events that happen on a developing brain before birth. These disorders are non-progressive, meaning that they don't progress into disease or worsen over time. There is no one cause of CP, and it is developed by various factors occurring at different times which act together to inflict damage on the brain. The location of the damage in the brain is what defines the type of CP developed. If the motor cortex is damaged, then spasticity and excessive stiffness of the muscle occurs. This damage can also lead to hemiplegia, paraplegia, and quadriplegia in children. If damage to the basal ganglia occurs, then dyskinesia can develop, which affects the muscle's resistance to stretch, resulting in involuntary movements. Balance and sensor coordination in space relates primarily to ataxia CP and is caused by damage to the cerebellum. There are many therapies such as occupational, physical, behavioural and psychological which act as interventions and help individuals with CP live as comfortably as possible. Additionally, there is no found cure, but MS, magnesium sulfate, has been studied as a possibility for preventing the onset of CP in preterm babies. Furthermore, exercise training is a successful intervention in the management of this disorder due to its benefits in strength, lung and heart function, mobility, activity participation, and social bonding. The research for the benefits of exercise training in this population is extensive, and there have been no reported side effects. And this concludes my presentation on cerebral palsy. Hope over the last 15 minutes or so you have learnt about the disorder, which consumes the lives of 34,000 Australians. References are under the video.